How does being an amputee affect your life?
Oh, wow, that's a huge question. Before I became a prosthetist, I would say very minimally. Like, I'm someone who just puts it on in the morning, takes it off at night, tries to pretend it doesn't get in my way all day.
Mm-hmm.
Now it's like every day, all day, it affects my life, but in an awesome way.
Welcome to The Summary, a podcast from Mary Free Bed, where we explore physical medicine and rehabilitation, one topic at a time. Together, we will gain insights, discover innovations, and deep dive into the latest developments in the field.
All right, Una, we have a great show today, something near and dear to your heart.
Absolutely.
What do we got going on?
Today we're actually going to showcase our wonderful clinic. I think it's one of the oldest clinic. It's called Center for Limb Difference that we have at Mary Free Bed. And basically it's kids with, it's like a interdisciplinary clinic that we get to see a bunch of our amazing kids with limb difference or limb loss. Yeah. So we have two amazing guests who are a core part of this clinic as well, Dr. Fornes and Katie Thorpe, who is our prosthetist as well. We'll actually have you guys introduce yourself. Dr. Fornes, Mike.
Yeah. I started out in practice back in 1989, was up in northern Michigan, but I've always had a real joy and interest in prosthetics and children with limb differences. I was in private practice up north for about 15 years, and then they asked me to start the peds division at the Children's Hospital, so I did that for 10 years. And Dr. Buckery, who was instrumental in maintaining this clinic, retired, and so I had the opportunity to help out with the clinic, and so I've been able to do that ever since, so it's really been lovely.
That's awesome.
Love that. I'm Katie. I joke around. I've been at Mary Free Bed since 1985. You got me beat. I was born with a limb difference, so I've been wearing a prosthesis forever. But I didn't really get interested in the field until I met another amputee, like in the wild, and sat down, had a conversation for like an hour and a half, and realized like this connection is awesome. Like, I'm so excited to talk to somebody who gets it. And I was 27. It took that long for me to run into somebody else. So that got me to go to Eastern Michigan, get my master's. I came back to Mary Free Bed in 2017 as a resident, and I've been here ever since.
Wow.
So all three of you are part of this clinic. Tell me a little bit about how this operates and what kinds of kids you see and what you do in this clinic.
All right. It's a multidisciplinary clinic where the family, the parents, really are the leader of the show. Really try to make that emphasis when we see children. So a child comes in to see us, and we have myself, an orthopedic surgeon. My partner, Lisa Maskell, is also an orthopedic surgeon, but she does mostly upper extremities, so she'll see the kids with the upper extremity involvement. And then we have Dr. Sinsky, who's done the fellowship in prosthetics, so she ties it all together. And we're fortunate enough to have physical therapy. Our physical therapist only has 35 plus years of experience. She's wonderful, Julie Honeycutt. We have occupational therapist, social work, nursing, and then we have ties through the Mary Free Bed system where we have recreational therapy. We can get consults with psychology. So we have it's truly a wraparound program, and it sometimes it takes me a while to explain to the family the importance of regular follow-ups because kids change so much. As they grow. Elementary school is different than middle school is different than high school. So we try to see the kids every 6 months or so and go from there. So that's just a brief summary on how the clinic works.
And you've talked in the past about the benefits of having the kids meet the other kids and the parents meet the parents. Tell us a little bit about that.
Back in the day, it was a ward. So all the kids were together, and it was really lovely. Privacy is important, but some of the little kids would really benefit from being together, and so we have our clinic here, and we see patients simultaneously, but they're in different rooms. But we have a picnic every year where we get all the kids together. Anybody that wants to get together can. And the people that go just come away just shaking their head how happy they were because they meet friends. They realize they aren't the only ones out here. And the parents talk to each other and can talk about all the issues and whatnot. So that's it. And we have other outings and stuff we try to do during the year also.
A little plug, the picnic this year is going to be a baseball game, a Whitecaps game,
yes,
so
yes,
watch out
yes.
for that at the beginning of
August
August.
2nd. Everything's covered. The tickets for the family and the patient and food, drink, it's all included. So
Super
just have to
excited.
sign
It's
up.
gonna be great.
It's gonna be pretty exciting. Yeah.
So Katie, you had quite a few surgeries, right?
Yeah.
Kind of walk us through that.
Yeah. So my limb difference is called proximal femoral focal deficiency, or PFFD. So it basically means my femur's really short and my hip joint is not great. It's not a great like ball and socket joint. There's varying levels of that, and I'm fortunate enough to be class A, which is like the most formed hip joint, which is great. But I had a Symes amputation when I was a baby, so they amputated my foot or disarticulated my ankle. And then I had my knee fused later when I was 7, just to create more stability in the limb, because I would fall a lot, having my hip and knee so close to each other and just both able to move and wiggle around. And then when I was 16, then a physician at U of M went back in and helped reconstruct my hip a little bit. I used to dislocate a lot. So after that, though, things have been great. So
How old were you when you did your first surgery, and how old were you when you did your last surgery?
the first one, I was 8 months old, which I'm impressed that my mom just like had faith in Dr. Buckery, actually was my doctor at the time, and just said, whatever you say, I'm going to go with whatever you guys think is best. And that was awesome. So I've actually called her and said thank you for making those tough choices early on. And then my last one, I was 16.
So you were happy that your mom kind of made that decision for you, and
Definitely. I'm sure it wasn't an easy one to make, but I've been very successful using a prosthesis since then. And now that I've seen patients, like children and adults, with the same thing and different like surgical approaches, I feel lucky that I ended up where I'm at. So, yeah,
that's awesome.
she's great.
How does being an amputee affect your life?
Oh, wow, that's a huge question. Before I became a prosthetist, I would say very minimally. Like, I'm someone who just puts it on in the morning, takes it off at night, tries to pretend it doesn't get in my way all day. Now it's like every day, all day, it affects my life, but in an awesome way. Like, getting to connect with patients, getting to share stories sometimes just share, like, can you believe how bad the parking is out there today? Like when the snow plows come through and stuff. Just those little ways. I'm really lucky to not have to deal with a lot of pain. I don't have a lot of issues with my prosthesis. So I think it helps with patients just to like be positive, give them some optimism on where we're headed. Yeah, I would say the effect in my daily life is actually really good, really positive.
You can relate more with the patients you see.
Yeah. I think especially with the kids, it's nice for me to be able to walk in and show the parents that, like, I'm also a very emotional person. Sorry, guys. Get ready. To show them that it's going to be okay. I mean, what better example than somebody who's been using one for 40 years and working full-time in a job she's passionate about? Like, I can't really be a better billboard for, you know, for Mary Free Bed and for prosthetic care. So it's great.
And the families really, really appreciate you too.
They
I
do.
hear it all the time. Yeah.
Thanks. They do. It's really awesome. I never thought that this was kind of where, you know, again, I'm an emotional person, excuse me, but when I was born, they actually told my mom I would never walk, which is crazy. They said, your daughter is going to be crippled for life. Like, even that word makes me cringe. And so every day that I get to walk around this place and, like, do my job and help others walk is awesome.
I wonder how many kids actually hear that, you know, and families. And
I know.
Yeah.
I hope never these days. I hope everyone says, there's a chance, let's figure it out. Because that's what we do a lot, is figure it out.
Not to say you're that old, but that was a little different time back
Yeah,
then.
it was. It was.
Yeah.
So, Mike, PFFD is, to me, it's an interesting disorder, and probably from your perspective, not that rare, but really, in reality, rare. But it varies in its intensity, and I'm interested in some of the things you do surgically now or non-surgically to help these kids, specifically with PFFD.
Yes, to go back to Dr. Aiken in 1945, he came up with a international nomenclature for PFFD, and it was real simple, typical orthopedic categorization, A, B, C, and D. A, the ball and socket are there, not totally normal, but it's present. B, there's no neck and behind the ball. C, there's really no head or socket. And D, there's just a little bit of femur at the knee. And so there's a dramatic difference in how you take care of those. So the first thing we do when we see a child is talk to the family about, we take x-rays and we evaluate the child and try to decide what category they best fit in. And I have to say, a lot of the kids that we see, thankfully, are in the A group, where we have a hip to work with. And so we basically come up with a surgical diary or a planning book for the patient. And I didn't come up with the idea. A guy named Dr. Paley, and who actually came up with the idea, but kind of came up with a roadmap. Okay, we're going to do this at this age, going to do this at this age, on down till they're fully grown. So we initially start out when they're little, just putting a lift under their shoe to keep their legs relatively close, and then around age 3.5 or 4, we'll reconstruct their hip. We'll realign the femoral side or the thigh side, the ball side, and then realign the socket. So both articulate and are much more stable and are apt to dislocate.
And this is the age you're talking about.
Yeah, around age 4.
I mean, that Class A.
Yeah, that Class A. Yep. And
But is there a reason why we wait till age 4?
well, because I don't have hardware any smaller than that to fixate the bone. And it's called infant blade plate that we use. And there just isn't anything made that's any smaller. And it's also helpful because the families, the child and the family have gotten to know each other. Life is stable right by that age. It's clear the child's going to walk. We put a big lift under their shoe, and kids can do anything with anything. They're just amazing. And so they're medically stable, they're physically stable, and then again the hardware fits into their bone. And so we'll reconstruct the hip around age 3.5 or 4. That'll heal, and then a year later we take the hardware out, and a year after that, around age 5 or 6, we talk about lengthening. And that's the reason that we fix the hip, is because lengthening the thigh bone actually puts tremendous pressure on the hip and can actually dislocate it while you're lengthening.
Oh, wow.
And that's not good. The other thing these children will often have is be absent. They won't have the cruciate ligaments in the center of the knee, the ligaments that the football and basketball players always tear, and they're having reconstructed. Well, these kids are often born without those ligaments. So at the same time we're doing their hip, we will often make them ligaments out of a strip of fascia or leathery tissue on the side of the thigh. And so we use their own equipment, as I like to say, and make them ligaments all at the same time. And again, to make the hip stable and the knee stable, so lengthening doesn't dislocate either one. And then once that happens, we go through the lengthening process, and it takes about a year. And when I say a year till they're kind of back to normal. The lengthening process itself actually only takes a couple of months, but then the bone has to fill in, and it has to get tough. And then after that's all done, we actually use kind of an erector set on the outside of the leg. And once that's done, we take the erector set off and then just work on physical therapy to get motion back and strength back. And then another 3 years goes by, and again, we pre-planned this. We'll talk about doing the second lengthening and kind of go through the process of lengthening the thigh bone again. If the family isn't interested in that, which is understandable, or if the child actually needs 3 lengthenings, sometimes we'll slow the long leg on the other side with what's called an epiphysiodesis. There's growth plates at the end of each of our long bones, and what we'll do is put a couple of screws across the growth plate under x-ray through little tiny incisions, and the patient can actually walk the same day. And that'll slow the growth when timed properly, so we possibly can avoid that 3rd lengthening.
I'm always surprised how they can just walk that exact day because it looks so painful.
The cross screws? Yeah. It works. We put a little numbing medication in there and send them home with some Motrin and Tylenol, and they do pretty well. Pretty amazing. So that's kind of what we do with PFFD. That's kind of the game plan. It's amazing how well the children do. Again, kids are so easy to work with in a lot of ways. So, yeah.
How about the more severe, like the C's or the D's?
Thank you. Let's go with the C, for instance, where there's really no ball and socket. Mother Nature still makes a muscular sling, and the children can still walk on it. It's just that they have a bit of a limp. So what we'll do is we will do the Symes amputation, as Katie alluded to, and then around age 5 to 6 to 7, depending on how fast the child's growing, we'll fuse the knee joint and stop the growth in that thigh bone.
So then they're effectively getting treated like above the
An
knee
above-knee
amputee.
amputation.
Okay.
Yep. And so the children can function quite well.
So even if you don't have fibular hemimelia, you would still do a Symes amputation.
Yes, and we'll talk about fibular hemimelia in a little bit. But yeah, the Symes amputation is what that allows us is to. A Symes amputation, we take disarticulate the ankle, but we keep the heel pad from the foot on the end, so the children can actually bear weight on that. So in the middle of the night when they get up and got to go to the bathroom, they don't have to put their prosthetic leg on. They can, just get around on that end, and it doesn't hurt. So it's a really functional amputation, and that brings up another thing: is people always think of an amputation as a failure. But in certain circumstances, congenital circumstances and other, a well-timed, well-thought-out amputation that everybody agrees to can actually be a really life-improving concept.
Mm-hmm.
So,
Definitely.
Yeah.
I'm always amazed in clinic because you always talk about the amputation process, surgical process, really early on. And it's like every visit, exact same conversation of like, okay, like this is what the process is. It's going to come one day, but like just keeping it in the mind and educating the family and getting the mind and the heart prepared for both the child and the parent. I always like find that so amazing how like consistently you do that each clinic.
No, and you're right, and I think, and that's where it's a team sport. Then the mom and dad and the patient can go home and talk about it, and so it's not something we're doing to them. It's something we're doing for them, and that's really important. Yeah.
Great.
Yeah.
I like that social work is always part of the clinic too.
Always.
So if there's other questions or other issues going on, as the kid starts thinking about that surgery coming up, then she can kind of step in and help guide the family there too.
Yeah.
Making those decisions.
There often, there's some bullying that goes on in elementary school and middle school, and sometimes I'll actually get involved because what I found is it's the kids ultimately aren't mean. They're just afraid or ignorant. And so we go and explain why they've their classmate has a bionic limb. They're like, wow, I didn't know that. And you don't realize how brave your classmate is. They've been through a number of surgeries and they didn't complain. They just went through it. And they're actually to be admired for their bravery. And by the time I've gotten done a couple of times talking to classes, it's like the whole attitude shifts.
Oh, that's
So
amazing.
it's information.
That's awesome.
Yeah. So, and that back to what our social worker does, Amy. It's so important because again, in elementary school, get some bullying, or in middle school, things change, and then I'm often talking to the kids a lot about. It's so important for them to realize that they aren't their amputation. They are a smart, good-looking, intelligent individual with a lot going that happens to have a short limb. And I try to impress that on them. And I don't know that everybody talks about it that way, but we have all got something. We just do. It's part of the human condition. We're all, some of us have crummy eyes, some of us have this, that, and the other thing. And so I think that's important in our clinic to talk about that. It's almost a spiritual thing. Who are you really? You are not an amputation.
Yeah.
So, yeah.
I spend a lot of time asking people, what are you doing all day? What's going on this weekend?
Yeah.
Just asking. I have a few patients right now that are like preteen girls, and they start having body image issues and these kinds of things. And so I start focusing on like, what makes you strong? Like, what sport are you trying? What else is going on? Just the same thing to remind them that, like, even though you're in my exam room and we're messing with your prosthesis today, like, that's not the only cool thing about you. It's really kind of great that we get that opportunity to follow them as they grow, too.
Yep.
So you've known them since they were 4 or 5, and then you got this 13-year-old in front of you, and you already know how to talk to them and how to help encourage them and how to listen to them, what they're actually asking you for when they're asking certain questions. It's really awesome.
Yeah, great.
So we have, Katie, a very huge adaptive sports program. And my question really is, I know a lot of these kids are involved with that. To what extent do you see kids interested in being involved in adaptive sports versus, I'm going to try normal sports?
Oh, that's a great question.
Yeah.
The majority of the patients that I see are just playing sports through their school or club teams.
Yeah.
I've had a few people ask me about adaptive sports, especially patients that maybe weren't as athletic when they were younger. I have a couple like in their teens that want to try things out, and I think it's a great safe space to go try around other kids with like similar function. But a lot of my pediatric patients are just playing on the regular teams. And they come to me and ask like, "Hey, how can I run faster? I want to play tennis. What can I do for that?" It's been pretty awesome.
You're really involved in the everybody can move, right? Tell us a little bit more about that.
Yeah, thanks for bringing that up. So Everybody Can Move is a national campaign that was started by a person with an amputation that wanted to learn how to run and couldn't get a running prosthesis because her insurance said no. That's over and beyond, basic prosthetic care. So she took it upon herself to prove that wrong. And she actually ran, swam, and biked down like the entire West Coast. You can look her up online. Forrest Stump is like the name of her short film.
That's such a good name.
It's great. The name of her short film, that's Nicole's baby. And out of that, she started this organization called So Everybody Can Move. And it is going state by state to try to update legislation to allow amputees to have more than one prosthesis. So, for example, when I do ride my bike in the Fondo in June, let's
and
go.
beating me.
I use a prosthesis with a free swinging knee. So it doesn't have any hydraulic resistance. It doesn't have anything preventing me from pedaling as fast or slow as I want to. But I've just cobbled that together out of like old prostheses of mine that have broken or like donated parts. That's not something that my insurance pays for. And that's common for a lot of people, even our kids. So Everybody Can Move is trying to update that legislation to allow for activity-specific prostheses to be covered by insurance. Or I should say not allow, but requiring it. So a lot of our pediatrics that want to learn how to run or want a swimming leg, we're in Michigan. Try keeping your kids out of the water here. This campaign is going to help a lot if we can get that passed in Michigan. So
we need all the voters out there to call your state congressman or state senator and encourage them to vote for this. It's really important. All we can address is Michigan right now. About how many states? 15, 20 states have passed it already?
Yep, I think we're at 15.
Yeah, and so it's really exciting stuff, but this is where voting is important. And so use your right here in the United States to push this.
Definitely. And I've been surprised at how easy it is to have conversations. Like, we've had several senators and representatives. I think we're like 25 or 30 one-on-one meetings that we've brought them into prosthetic clinics and showed them what we're building, what we're making, what we're doing. The questions have been great. The feedback has been great. We're working on language for that legislation right now and getting a sponsor for that bill. And then you're going to probably start to see us get pretty loud about it. We're going to take a bunch of patients to the Capitol. We're going to show people what we're doing with prosthetics, what we're capable of doing, and then start asking for them to get behind this bill and support it. So keep an eye out for that.
Because I think simply people don't understand that there is a difference, that our leg muscles and bones are versatile, while the prosthesis unfortunately still has its limits, and having these activity-specific limbs are just detrimental.
It's kind of a no-brainer, too. Something that I've talked to people about is just even saying, tell me how many pairs of shoes are in your closet. You don't wear the same shoes to church and then hiking and then to the beach, so why would we wear the same leg all the time? And that kind of helps bring it into like a more practical frame, and it helps people understand a little better.
I love that.
What are some of the other, I guess, types of prosthetics or feet or something for different sports or activities?
A lot of it depends on the shape of the foot and what it's constructed out of. So sometimes you'll see, like, the Paralympics just happened. You'll see those big, like, C-shaped, they look like a big spring. Those are great for running. But when you're walking,
they're made out of carbon fiber, so they have tremendous, they store energy.
Yeah, they really do act like a big spring when you really put your weight through it and put force through it. But if you walk in one, it's like walking on your tiptoes. I don't know if you've ever looked down when they're walking, but that pad is maybe like the size of a deck of cards. So it's not something you're going to just wear to school on Monday. But to your question earlier of kids who want to play sports and join in with like their teams and their peers, stuff like that is huge. For people that are going in the water, there's different feet that are waterproof, or they can be cleaned out easier if you get them full of sand. Instead of grinding away all the carbon in there, something that mom and dad can take apart quick, rinse out, and put back together. There's tons of stuff out there.
I think one common question that I get a lot in my clinic is swimming. Do you need a prosthesis specific for swimming, or do amputees choose to swim without it? What is kind of your experience?
I think I've seen kind of 50-50. Where
Depends what they're trying to do. If they're swimming for speed, my sense is, I mean, if they're, because I've got a number of swimmers in our clinic, and if they're swimming competitively, they don't use any limb at all, I don't think.
Right.
But if they want to go to the beach and walk in and out of the water, that's really what we're talking about, which is the norm.
Yeah, I would say I'm the same. At the pool, I have it off. You know, I get myself to the edge, somebody runs it back to the towel, and I just jump in.
I thought you were going to say they had to push you in.
Take the slide. Yeah, and then at the beach, it's definitely nice to be able to walk in and walk out. But to your point, usually we're not having people use their daily driver for that, because then the whole thing is wet. They're putting back on a wet interface. Skin integrity starts to get compromised. To be quite honest, they get funky because if they're getting wet all the time and things aren't drying out right, it gets to be kind of smelly. So with the legislation and insurance regulations how they are now, sometimes we're having patients kind of use their last prosthesis for that. So even though they outgrew it, it might not fit perfect. Maybe it's enough to get them down to the water and back. And then they can put on something clean and dry after. But same with showering. I have quite a few patients that would prefer to shower with that. But again, it's just difficult to maintain hygiene and maintain the componentry when you're getting it wet all the time.
Yeah, showering while standing is definitely a request I get a lot. Like, I
it's
miss
game
that, I
changer.
want to do that. And I'm like, that makes sense. You know, we don't think about these things.
Yeah. And then tell a 7-year-old to sit on a shower bench. It's not going to happen. They're going to be standing there on one foot and then slip and fall. It just gets ugly.
So how do you deal with growing kids? Their residual stumps get thicker. They're growing tall. How often are you changing sockets or lengths or whatever?
Yeah.
New prostheses.
Yeah, I would say we're changing them at least annually. I've seen them
to a new prosthesis.
Yeah, or at least the socket. So the
Okay.
socket or the interface that actually connects with their limb, that's going to be the thing that they outgrow, so to speak. Volume's going to change, length of the limb's going to change. And then componentry, sometimes they'll still use the same foot from one socket to the next, like if their weight hasn't changed very much or their shoe size. But I would say with kids, we're replacing things at least annually, sometimes more like 6 to 9 months if they're really growing. They hit that growth spurt during puberty, and it's like, boom, all of a sudden, we just had one that's like 2 inches out of the socket all of a sudden, and I had seen her like 2 months before. She just shot right up. So there are certain things we try to build into the socket to kind of expect that that's going to happen. Some practitioners will use an onion skin type of approach, so they're actually building a couple of thin layers inside the prosthesis that can be removed as the child grows. So that helps with volume change or weight gain. It doesn't help as much when they're getting a lot taller very quickly because they're still going to sneak up and out of the socket, but it can help with longevity a lot. Some of the other components, we have a lot of different alignable metal components that we can exchange in and out. So especially like above the knee amputees, if they do a lot of growth, sometimes not a lot of that's in the femur, but their overall height changes. So we can put a longer pylon in and just kind of grow their prosthesis up with them. Sometimes too, we'll build them a little bit, I don't know how to say it, a little bit big. We have them fit with like a little thicker sock, and then we know as they gain a little weight or start to grow, then we do a thinner sock and a thinner sock until they eventually outpace it.
Yeah, because
There's
they grow
lots of approaches.
circumferentially first, right? And then they grow height. So you kind of like
Exactly.
gauge that timing.
Yep. We do our best.
Yeah. They're just going to do
But
what
it's a
they
lot
want.
of chasing. Yeah.
And are these changes, components typically covered by insurance?
Yeah, I
For
would say
growth?
so. A lot of insurance is based off of medical necessity, and it's very clear when we can say, look, this patient grew 2 inches in the past year. That's where the clinic is really great, too, because we are getting eyes on them every 6 months at least to check in and say, is this actually fitting, or are you just running around on it and it's fine to you because you're 8, but we look at it and go, holy moly, this is broken in half. But yeah, usually if something's really broken beyond repair or they've changed enough, then we have that medical necessity to replace it. We try to be as conservative as possible. Everybody has co-pays and deductibles and things like that. This is the last thing you want to spend your money on. So we try to make sure that we're being sensitive to that too.
I think what I love about our clinic is that everybody is there, all eyes are on, and everybody has their own expertise. And if the child needs any adjustment in their prosthetic socket or any componentry, you guys are there to fix it immediately within that clinic visit. So it's like a one-stop for all. And I don't think that's that common outside of the Mary Free Bed.
I don't think so either. But you're right, having that sort of pit crew, because sometimes it is something as simple as, oh, they're about a half an inch short. Can you guys just scoot them up a little bit? It's nice to have, Jim does that for the clinic right now, just to have him jump in, handle that, set up a follow-up, and just get them to keep moving. Yeah, love that.
Wow, and you guys just have tremendous experience in this clinic. I mean, people have been there for a long time.
Yeah.
Except for you.
Except for me, I'm the newbie.
But you're learning.
I'm learning.
And I think that helps when you've got, issues that you can't necessarily read a textbook and know what to do in these situations, and you tweak things here and there. And then, the personal side of things, knowing what these patients' families are likely going through, and maybe they don't even know what questions to ask, and you guys know because you've been doing this for so long.
Right. I think it's rare to have the volume of patients that we get to see over time.
Yes. Yeah.
I've talked to other colleagues in other parts of the country or other hospital systems, and they maybe see 1 or 2 pediatric patients a year.
Yeah.
And we
wow.
see, dozens and dozens and dozens. So it's really great. Yeah. Even being able to collaborate among staff. If I haven't seen it before, there's probably another prosthetist in our group that has. So we ask each other a lot of questions. hey, how have you dealt with this? Have you had good luck with this sock? What do you think of this knee? And that stuff's like,
There's an organization
valuable.
that was started here by Mary Free Bed back in 1976 called ACPOC, and it's the organization that connects all of the major clinics in the country, and there's a finite number. So what you're saying is right, and they get once a year they get together and they go over the new prosthetic and orthotic changes that have occurred, and they have multiple case studies where they'll talk about difficult clinical situations, and there's a lot of exchange, which is what you're talking about, just sit around and say, what did you do in this situation? How can I better take care of this problem?
those are amazing to watch.
Yeah.
They literally will have an open mic and
Yep.
say,
That's awesome.
what do you guys think of what we've tried? Have you seen this before? Come up and tell us what you think.
Yep.
That's awesome.
Yeah, it's really helpful.
And in 2027, it'll be right here in Grand Rapids.
Yep.
Coming
Yeah.
back.
Yep, it was
We're
back last
excited.
year in 2016, and it's going to come back in
Yeah,
2027.
we're excited.
Yep, just in time with the new children's rehab hospital.
Yep.
That's true.
Indeed. The other thing our clinic does, we don't just take care of congenital problems, we also take care of the children that have had oncologic or problems or cancer and have had amputations. And we also take care of kids that have had traumatic amputations, be it lawnmowers and whatnot. And so we try to, and each child has a different issue, because obviously, if they've had cancer, they've been through a lot. Their tissues aren't as forgiving, and so prosthetics have to sometimes be approached in a little different fashion. And the same thing with the post-traumatic. Sometimes the skin and soft tissue has been really damaged, and there's a lot of scar that the prosthetist has to deal with to keep the child comfortable. So we have that whole other arena and group of children that need to be taken care of. So, yeah.
So these kids really need a multidisciplinary, experienced
Yeah.
clinic.
They're carrying around so much, I don't want to say baggage, they're carrying around so much history and trauma and some anger and shame and just a lot. And then the families come in, the parents, it's the same thing. They feel bad that this happened to their child, and could they have done something differently? Could they have been better parent, or have they doing enough? And so we try to keep that in mind, that oftentimes the family's suffering too, and we need to address that, and that's part of what Amy does and part of what we all try to think of. So there's layers of stuff. Not only is their child need a prosthetic, there's issues with that prosthetic and growth, and then there's insurance issues. The insurance company doesn't want to pay for something, or they have Medicaid and they have to sign X number of forms, and you missed one, or you missed a repeat sign-up, or Children's Special Health Care. The insurance company will pay for something, but the other won't, and so they're fighting with each other. And so there's all of this stuff, and the finances are an issue. I mean, when I think about making an appointment for somebody, I got to remember that I'm asking the family, the parent, to take a day off of work, and they got to travel. And then they get the privilege of paying the copay or the deductible on their insurance. So this stuff's really, really expensive. And so trying to be cognizant of all that, Amy kind of keeps track of, is their insurance still working? Are they having difficulties? Even bringing you onto our clinic was such an addition to our clinic in terms of expertise. But we fretted about, oh my God, are we going to make their bill bigger? And so we look at the schedule every day. Do I need to see every patient? Do you need to see every patient just to keep the bill less? And the families don't even know that we're agonizing over this. So it's a complicated process.
I think that's where we can shine as clinicians sometimes, is some of that weight that we can take away without them even knowing or without them even feeling it.
Yeah.
Being able to have the answer already in front of them before they think to ask.
Yeah.
Just those years and years of expertise are really special.
Yeah.
Yeah. That's something I feel like is great about my personal experience here too is just being able to walk in a room. It's like you almost like see their shoulders just drop a little bit of like, okay, this is someone that is going to understand. And like they just that wealth of knowledge to I think be able to lighten that load, just even the smallest amount is huge. It's really cool.
Yeah, I think as a pediatric physiatrist, as interested as I am in amputee care, I don't know like hardly anything. And if I saw one on my schedule, I would say no, go over to the clinic. And it's not really, there's a physician side, there's, most therapists, physical therapists don't see much amputee, especially in the pediatric world. This big experience clinic, I mean, it's worth a long trip for some of these parents, really, in the long run.
Yeah, people come from really afar.
Yeah, now we've got people come from the UP, we have people come from other states. Back when the clinic started, it was the only one in the country, so people came from all over the country. In Germany, back as they had all the thalidomide kids, used to come here from overseas.
Yeah.
Yep. We haven't talked about fibular hemimelia, which is another very common congenital problem. Children are often born without the smaller bone in their leg between the knee and the ankle. It's called the fibula. The tibia is the one that bears most of the weight. And they're born without the fibula, so the foot, therefore, is often flopped off to the side. And associated with that, they're often missing 2 or 3 toes on the foot. And so the question is, do we try to reconstruct what's there, or is it kinder to the child to do an amputation at age 1 when they're starting to pull up? And the reason this is somewhat controversial is when you're 2 or 3 and you only have 2 or 3 toes, you can walk just fine. You can walk just fine. Even if your foot's tipping off to the side, we can put a little orthotic on there, and they're just fine. The kids only weigh 20 pounds. But when they weigh 180 pounds and are 6 foot tall, a 2 or 3 ray foot doesn't hold them up very well. And so part of our job is to look ahead. And how is this child going to do long term as an adult? Are they going to be able to carry out a job where they got to be on their feet all day? And so we have to, and the parents have to make the decision, but we try to give them the pros and cons of decisions. So in fibular hemimelia, when they have all 5 toes, we often will reconstruct. But when we only have a foot that has 2 toes or 3 toes, sometimes the kindest thing to do for the child is to amputate. And that sounds crazy, I realize. But it's one surgery. We fit them with a prosthetic, and they can play sports. There are no limitations. They can play baseball, football, basketball. There are no limitations. Whereas if we reconstruct that foot, 1 or 2 surgeries, then we have to do at least 1 or 2 lengthenings because the tibia is often very short in fibular hemimelia. A couple of lengthenings. Those are each a year-long process. So now we've taken a minimum of 3 years out of that child's childhood. And there's no guarantee when we're all done that we're really going to let them play any contact sports because we don't want them to break anything. So, which is better? And this is for the family to decide. But we have that long-term knowledge that you alluded to, Dr. Henry, that we can say, hey, this is what I've seen in this situation when a child is fully grown and an adult. This is what I've seen when we've done the Symes amputation. And yes, the prosthetic needs to be changed every year. Yes, it's a pain at times, but they're one surgery, they're fully functional, and there's no limitations. And that's not true every time, but the majority of times that is true. And so that's a whole nother area of this clinic that we really can have a positive impact on the family. And that goes back to what I was saying before about an amputation isn't a failure. It may be part of a great treatment process that enhances the person's life and actually makes their life easier. So that's another area that we deal with. We deal with other kids that have significant leg length differences, and we'll do leg lengthenings and whatnot. And And then some children are born missing part of a foot or part of a part of an arm, and we haven't talked a lot about upper extremity stuff. And so that's where orthotics will come in to fill in what's missing in the foot. And then in the upper extremity prosthetics, that's a whole nother arena. When I was in my fellowship in Scotland in 1989, they were working on myoelectrics. It was really cool how, they would have electrodes over muscle groups in the arm that existed, and they could make a hand open and close on, but they were terribly heavy. So they really weren't functional. And so as time's gone on, the prosthetics, the myoelectrics have gotten a whole bunch lighter, and really, really exciting things have been made. Having said all that, if I've got a child that has an amputation through their forearm, mid-forearm, from birth, they have full sensation on the end of that. I have kids that can put their socks on faster than a two-handed, able-bodied person can do, because they have sensation there. So when we put a myoelectric prosthesis on, we all feel good because they've now got a hand that can move. They don't have any sensation in that. And so in a lot of situations, it's not really helpful to them. So what we try to do in kids when they're young is fit them with a prosthetic that doesn't do a lot, just has a hand on it, so they get used to it. And they're going to reject it most of the time, but we keep going back, and so they get used to the idea. So when they're in middle school and they say, I really want to play baseball. Okay, we can set you up with a prosthetic arm and put a hand on there that can grip a bat. Away you go. And then you take the prosthetic back off, or ride a bike, or play golf. And so a lot of times the upper extremity prosthetics aren't worn all the time. They're used for function. And that is a really, really fun part of this clinic to just to figure out how can we make this child more functional and so they can have more fun. We've even gone so far. I've seen we'll adapt the handlebars on a bike, so the prosthetic is actually on the handlebar. So the child just jams their forearm into the prosthetic, the handlebar, and away they go. And again, kids don't care; they just want to go play. And so there's all sorts of adaptions that can be made, and that's what's kind of fun about this ACPOC meeting is somebody's always coming up with something crazy, some crazy harebrained idea that is just wonderful, and really helps these kids out. It just works perfectly. Works perfect, yeah. And oftentimes it's different for every kid, and that's where to me, that's where the creativity comes in this clinic and in prosthetics. It's not just doing the same thing over and over. It's you got to be creative to come up with things that fit each child. So, yeah.
Yeah, and you never know when the child is suddenly going to say, I do want a prosthesis now. Mm-hmm. And I love it when they walk in. It's like, actually, I want to try this now. And sometimes it's like body powered. Sometimes they want to go back to body powered. Sometimes they want to go myoelectric. It really depends on. Sometimes it's about what movie they watch that day, on TV. And they're just like so excited about it, and it works perfectly. You just never know what you're going to walk into every day. Yeah.
Well, Mike and Katie and Una, this has been a very interesting, educational discussion. So I appreciate all three of you sharing your insights, and I've learned a ton. Almost cried a little bit at times. I can be emotional too.
I kept it together. I'm proud.
But thanks for all you guys do for these kids. I think this clinic that you guys run is fantastic, and I know it's great for the kids, and appreciate you coming here to share your expertise.
Thank you.
Yeah, I definitely look for many, many, many years to come.
Yes.
You can't retire. So.
No.
Thank you, guys.